Next speaker is Rose Seavey. So Rose Seavey is President and CEO of Seavey Healthcare Consulting and formerly the Director of the Sterile Processing Department at the Children's Hospital of Denver. Rose served on the AORN Board of Directors and is past President of ASHCSP. She received numerous awards such as AORN's Award for Mentorship and Outstanding Achievement in Nurse Education. In addition, she was given the Isham Award of Honor. Rose was also named as one of the who's who in infection prevention by Infection Control Today. Ms. Seavey is the author of the book titled Sterile Processing in Healthcare Facilities, Preparing for Accreditation Surveys, published by AAMI, now in its 3rd edition. She serves on several AAMI committees helping to write US national standards. Please welcome Rose.
Thank you, John. Hello, good morning, everybody. I have several colleagues and friends, especially from the north, that I haven't seen for some time. So I'm really thrilled to be here, and thanks to Nanosonics for allowing me to come and speak to you guys today. Every time I hear that introduction, it just reminds me how long I haven't been around. Like Ruth, I guess I am a classic. When I started, I had dark hair. So anyway, I'm going to talk about the traceability, but before I get started on this, you know, we as medical device reprocessors, or what we call in the US central sterile or sterile processing, we're not used to these devices because they're all over the place and they're not centralized, so we haven't always been the ones to reprocess them. But let me tell you, now we need to be more involved. We need to standardize throughout our facilities, et cetera. So I was thrilled to see that your standards specifically address that. And hopefully soon in the United States, we'll be working on something very similar. So anyway, I got 2 objectives. I'm going to identify your regulatory requirements and then describe some practical implications on how we can really trace these things. Because we know anything that gets reprocessed from one patient to the other must be traced from the time it's processed till it's used, till it's processed again. And so these things can be very difficult because, as I said, they're all over the place. They're not just in our centralized locations. They're not just in our ORs or EDs. They're used throughout the facilities. So first of all, let's talk about what is traceability. Well, traceability is the ability to be able to verify and the location, the application, and all of that information by means of documentation. So we can go back and find that information. So it needs to be in writing, basically. So why do we need to trace these devices? Many, many different reasons. We need to, especially for any kind of investigation, we might need to verify that we are conforming to the standards, that if there's any kind of product recall or if there's an outbreak, and sometimes just doing case studies. So we need to be able to trace these things. So it's not just for epidemiological reasons, of course that's huge, but also we need to be able to assess whether or not they got processed appropriately, et cetera. And let me tell you, if you've ever had an if you've ever been in on a legal case, and you have an expert witness, and I've been an expert witness many times, that's the first thing I'm going to look at is your traceability. You know, how can you prove to me that that product was handled the way it's supposed to be? So we need to enable that traceability for all of our medical devices. So you guys are very familiar with your standards, the Canadian standards, and basically Chapter 13, as Ruth alluded to, that is very specific to the ultrasound standards on probe reprocessing and the traceability section. So I'm just going to talk a little bit about that. Under Table A1, it talks about the identification and traceability. We must be able to conform to the standards. We, like for instance, when we sterilize something and we have a package that's sterilized, whether it's wrapped or in a container or in a peel pack, it gets a label on it. And then we have chemical indicators right there, external and internal, so we can always tell that it was processed, right? And we can trace that back to the patients. And we use lot control labels, you know, where we have our sterilization number, the run of the day and all that, so we can trace things back. But when we start high-level disinfecting things that aren't wrapped or aren't containerized, that gets to be a really fuzzy area. So on section 4.4 talks about the release of products. So we need to have evidence of that conformity to what the standards say. And the standards say that we must be able to trace. So the traceability to the person who's actually releasing that load. So just like with sterilizers, we have to release that load to be able to use on the patient. When we're doing high-level disinfection, we have to do the same thing. Somebody has to be able to release that to say, yes, it did get processed correctly. So section 13.4.2 talks about basically the sterilization methods, but under section A, section B talks about high-level disinfection. What kind of stuff do we have to trace? Well, we have to trace the product name, the lot number, expiration of the high-level disinfection, the date of the solution, the initials, all that kind of information. And then the test strips themselves. We have to test those, and we have to document that those are okay. And when and if they do, or when they do expire, and what the results of those test strips were. So those are kind of our chemical indicators, just like with our sterilization records. So section D under that talks about ultrasound transducer probe documentation. So I'm not going to read all that. I think you guys can see the bullet points, but all that information from the probe name all the way down to who was the staff that actually did the reprocessing, that needs to be documented. And then under section E, the probe reprocessing documentation, we need to document all that information about that particular probe. The date, anytime it had maintenance performed on it, all the way down to the date of new disinfection or when it was installed. So it's a ton of information, more so sometimes even than our sterilization. Like when we steam sterilize something, we don't have all that kind of documentation because our printouts are stating that. So under section 3.5 talks about records retention. So we need to retain these records for a long time, depending on what your facility. And usually each facility has a records retention policy that's a risk management policy. And so the reason it's under risk management is because if something happens, we have to go back and try to figure out what could have caused an infection, et cetera. Then we need to be able to go back to that. And remember, as Ruth was saying, our job is to reduce risks no matter what. And I heard something the other day that I really liked. You know, before we didn't know all the differences, and so we did what we thought was best, like you were talking about wiping things off with alcohol. But when we know better, we do better. And so now we've got a lot of research. We've got things out there that say, you know, we've got better ways to do it. But we also need to document what that better way is. So it falls under our risk management. So we need the policy needs to reference the regulations and the standards, and it is an individual organization policy. I can tell you in the United States a lot of times that we need to keep those records for up to 7 years, sometimes even longer. But you should check with your records retention policy. So let's talk about implementing traceability for ultrasound probes. It's very complex. As I said, you don't have a nice little package with all that labeling on it that you stick on the shelf. A lot of times, these devices are used throughout the facility, many different places, so it's really hard to standardize. So you need a standard operating procedure to be able to trace these items back to the patient, and whether they are used critical or semi-critical, and oftentimes the same device may be used as low level or semi-critical or critical. And so that's another big reason why we have to document and be able to trace how it was processed. And we know we've got many different types of probes. We got the intercavity probes, which really need to be semi-critical, and then we've got surface probes that can be low-level disinfected. But that same probe might be used on some skin or something that isn't intact. Maybe it has an abscess or something. Now we've got non-intact skin, so it becomes critical. So that means it has to have a different level. It really should be sterilized. But we know with these devices, it really can't be sterilized. So at the very least, we need to high-level disinfect and then use a sterile sheath. when you compare that to our flexible endoscopes, which we know very high on our radar right now, but at least with the flexible endoscopes, we know they have to be high-level disinfected because each and every one of those is going to go into some mucous membranes where maybe ultrasound probes might not. So that makes the probes even more complicated. So ultrasound probes can require, like I said, low, high, or sterilization. And because they come in so many different sizes, sizes and shapes and usage, we really have to document even more. So we have an opportunity for manual data collection, which we know is fraught with a lot of human error. And that's what we're doing mostly nowadays, especially if we are soaking these devices. And many places that I've been into are still using what we call the boats, you know, the glutaraldehyde boats or the soaking tubs or whatever you use. And that manual disinfection is really fraught with a lot of errors. And then when you go to trace it or document it, it gets even harder. But we still need to make sure that we maintain all that information about the probe and about the disinfection stuff, and then that needs to go into a logbook. But then we also have all this information we need to keep track of for the patient. So we need to make sure that we connect those dots. Some of us use a logbook. Sometimes, we have to handwrite that stuff, and, we're not always very good at that, are we? Sometimes we kind of get busy and we don't follow through. So there's an opportunity now for semi-automatic data collection where we actually can print out a barcode, and that barcode has all the information for the high-level disinfection. So it's got that the date and the time and the results of the minimal effective concentration, the MEC of the testing, the temperature and exposure time. So we can get that out on a printout on a little barcode, and then we could take that barcode and we can either put it in a log record or kind of attach it to the patient record by sticking it on there, so then we have some kind of traceability. Then the next thing we have is a fully automated collection system where we actually can, the machine actually will capture not only the date and time of the high-level disinfection and all that stuff, but the activation date, the shelf life, the person who is actually performing that, as well as the unique probe identifier, so the make and model, or maybe you call it probe A and probe B or whatever, and then the lot number. So all that information can be captured, and then there's also now an opportunity to be able to link that automatically with our medical records so that it eliminates a lot of that chance for human error with that documentation. So we're able to link those together. So, as I said, most of these devices are used throughout the facility, and a lot of times it's interventional radiology. And so think about this. Maybe at the beginning of the day, a probe is used on a patient just for a surface probing and intact skin. Low-level disinfection is just fine. But then maybe later on that day, that ultrasound probe might be used on a patient that has non-intact skin, and maybe you're going through an abscess or something like that. Now that needs to be sterile. So we need to be able to look at those devices and say, hey, has this been high-level disinfected or not? So we need to be able to, the actual device should have a label on it to say, hey, this has been at that level that I need for me to use it on this patient. Because remember, our whole job is about reducing risks. And so ultrasound-guided central line insertion is another one. As Ruth was talking about, now we are piercing the skin, right? And anytime we pierce the skin, now we don't have intact skin. And in that case, we need to have sterilization. With the probes, as I said earlier, really can't be sterilized, but at least we should high-level disinfect it and then use a sterile sheath. So, because of outbreak investigations, we need the importance of that traceability. There's many different examples of breakdown. For instance, if you have an outbreak, if you don't have all that traceability, then there's no record of high-level disinfection. You're unable to be able to trace that to that particular patient. The probe may cannot be excluded as the source of that infection. So it might have been that probe. That probe may not have been to the right level of disinfection, so we may have caused some of that infections. So having the ability to trace these things automatically will help accuracy, efficiency, and reliability. So the other issue is storing of these things. Many times we used to see these things just stored on the machines, just kind of hanging in the air. Hey, hi, I'm ready to be used. But we know better now, and your standards really talks about once these probes are processed, they need to be protected from the environment. And there are many studies out there now that tell us that the environment has a lot of contamination in them. So we need to, once these things are processed, we need to make sure that we protect them. And we protect them by putting them like in a sheath, a sheath that we can store them in, and then we can label that sheath that says, hey, this has gone through this sterilization or this high-level disinfection, and clearly label it, and so the next person will know that that's been done. And we also know that we can't store these in the same area where we're doing the procedures. They should be stored outside the decontamination room, etc. So we need clean, single-use storage covers that need to be labeled, and that label needs to stay on there from the time it's disinfected till it's used on the patient and disinfected again. So when we have this fully automation of being able to trace these probes, no matter where they're used, then we can be accurate, so we know there's a decreased chance of human error, very much more efficient because we streamline our workforces. We can reduce the time spent looking for that documentation, making sure that it's written in a place and that you have that right documentation. It's reliable because it's automatic. That data is there, so you can go back if you wind up having to trace a device because of a patient error. You can go back and have all that stuff, information backed up, and it's very secure with the HIPAA, so you know that the patient information isn't going to be written on all these different places, but we have all the requirements, and we're following the HIPAA. So, in summary, for traceability, documentation and demonstrations with compliance, regulatory and accrediting requirements, and it identifies any trends in quality improvement processes. So basically, if you think compliance is expensive, try non-compliance. As I always like to say, you do not want trial by 60 minutes.